Yeah. Yeah.
Good morning, good afternoon, good evening, depending on the part of the world that you are joining us from. My name is Angela Pratt. I am the Director of Communications and External Relations and Director of the Regional Director's Office here at WHO in the Western Pacific. And it is my privilege and my very, very great pleasure to be your moderator for this morning's event. So welcome to all of you to this forum, which Wipro is convening jointly with the Lancet COVID-19 Commission. Almost 12 months after the first cases of what we now call COVID-19 were detected, there have been more than 72 million confirmed cases reported to WHO from around the world. Very sadly, more than 1.6 million deaths. Just 1% of those confirmed cases and 1% of those confirmed deaths have been here in the Western Pacific region. So today we're here to talk about some of the reasons why this is the case, not out of any sense of complacency, on the contrary, rather in our regional tradition of learning, improving, and always preparing for the next event. We're here to talk about some of the lessons learned that can be learned from countries' responses to COVID-19 this year. We are going to tackle this discussion today in two panels. The first looking at the role of non-pharmaceutical interventions in suppressing transmission of the virus. And the second panel to look at the very important issue of establishing and maintaining social norms around the individual protective behaviours that we know are so important, as well as building community support for the public health interventions that have worked so effectively to suppress transmission of the virus in this region. We are joined by an absolutely terrific lineup of speakers from countries around the region today to take part in both of those panels, and I'll get to those in a moment. But before we do that, I would like to call on the chair of the Lancet COVID-19 Commission, Professor Jeffrey Sachs, who joins us from New York, to provide some opening remarks. Jeff, it's great to see you. Over to you.
Thank you very much, and good morning to everybody. It's really an enormous pleasure, and I'm very excited also to be together with you. Of course, there are so many challenges and so many things to discuss, but the starting point really is you've done a magnificent job, certainly in comparison with the rest of the world and in comparison with my country. And as chair of the Lancet Commission, I'm really eager to understand more deeply what is the magic sauce in the Western Pacific region that has permitted this comparatively superb performance. I know it's true also, every day is a challenge, and there are still a lot of cases, and there still is a lot of suffering and a lot of challenge. So I am not in any way trying to be grandiose or complacent or to overlook the issues. But let me say that when I added up, the Western Pacific region yesterday had about 5,300 cases for roughly 1.8 billion people, or approximately 3 cases per million population. The United States had 193,000 cases yesterday for our 330 million people, or 584 cases per million. So the US is running more than 100 times the incidence rate of the Western Pacific region. And there are, of course, ongoing community transmissions in several countries. Many countries in your region are battling right now new outbreaks or new surges, but it is still the case that the levels relative to population are low on an international basis. And I have a lot of confidence. I hope you don't dissuade me from that you will bring these new outbreaks under control as well. The Lancet COVID-19 Commission is charged with giving advice to the public and to governments and to the UN system about controlling this pandemic, suppressing the pandemic, ending the pandemic in an equitable and speedy manner. And so the experience of the Western Pacific region is of extraordinary importance. I've been referring to the success of the region every day since March, because it was already apparent in the early part of the pandemic that the Western Pacific was doing a better job of suppression than Europe or the United States or indeed the Americas taken as a whole. So without further ado, I want to thank all of you for your great work. And I want to thank you for taking the time this morning to be together to discuss the ongoing challenges, to explain what is happening, to compare processes in different countries. And please don't hesitate to give some advice to those of us who are in countries with rampant pandemic spreads, like the United States, 200,000 cases a day, but with an incoming president determined to do something about that, how we might proceed. So Angela, back to you, and with gratitude.
Thank you very much, Professor Sachs. It's great to have you with us and great to be working with the Commission on this event. Now it's my very great pleasure to introduce the WHO Regional Director for the Western Pacific, Dr. Takeshi Kasai, to provide some opening remarks. Adi, over to you.
Thank you very much, Angela. Good morning and good afternoon, colleagues and distinguished guests, and good evening to Professor Jeffrey Sachs. And thank you very much for joining this forum today. We are very, very pleased to be organizing this forum jointly with the Lancet COVID-19 Commission. And thank you, Jeff, for your support. Compared to other parts of the world, as Angela and Professor Sachs mentioned, our region has been comparatively fortunate. To date, we've recorded just 1% of confirmed case and 1% of confirmed death. Most countries have avoided the so-called red line on the point where critical care needs surplus healthcare capacity, large numbers of healthcare workers are infected, service quality decline, and death rapidly increase. We call this as red line. Of course, 2020 has still been a very difficult year, in particular for healthcare workers and for those who have lost loved ones and livelihood. It's been a very difficult year. And my thoughts are with the families of these people every day. And my thought is with the healthcare workers being working so hard over the past 1 year. And so we need to remain vigilant in order to keep case number down and health systems operating. And as far as possible, we wanted to make sure the transmission of the virus is in check. Today's forum is an opportunity to reflect on some of the lessons that can be learned from our experiences. There's no single or a simple reason as to why our region has fared relatively well. Clearly, long-term investment is critical. Countries in the region have spent more than a decade preparing for events with pandemic potential. By strengthening their health system in anticipation of an event like a COVID-19 pandemic. I myself lost my colleagues during the SARS 2003, and I myself committed, and I know that there are many people who engaged in the SARS also committed in a similar way. Under the Asia-Pacific Strategy for Emerging Diseases and Public Health Emergency, or APSET, now its third iteration, countries develop their response plans, and crucially, the capacities and systems to implement them. Under this shared strategy, systems were set up, such as for contact tracing, which have proven to be critical in the COVID-19 response. We also saw in places such as the Republic of Korea, the importance of quickly scaling up testing and linking this to the public health response. I understand that they really fully utilized the experience from the MERS outbreak in 2015. Countries had successfully controlled COVID-19, had a very strong public health plan to manage positive cases. Most countries were able to scale up the right mix of public health intervention at the right time to avoid the so-called red line, as I've already mentioned, where health systems are totally overwhelmed. China showed us early on that this virus could be suppressed with the right set of public health intervention. And Australia and New Zealand's experience has reinforced this. While countries were prepared for the worst case scenario, widespread community transmission was not inevitable. From Japan, we learned that the benefit of using a cluster-based approach. And of course, Japan also taught us about the renowned, the 3 C's. I understand that even the small kids in Japan knows these 3 C's, avoiding closed spaces, crowd places, and close contact settings. There are many other important factors. Good system for multi-source surveillance have been crucial to enable countries to monitor trends, assess risk, and adapt the response strategy accordingly. Communication from trusted source, including government, healthcare worker, and scientists, has so important for establishing and sustaining social norms around protective behaviors and building community support for public health measures. We have been observing very effective communication in many countries, including Vietnam, Singapore, and New Zealand. I've been impressed so many times with those member states' communication. I have also observed in many countries a strong community commitment to protecting the most vulnerable. And I am also very proud of the spirit of the solidarity that has characterized interaction between countries of our region this year, from technical exchange on issues such as laboratory testing and clinical management, and to working together in joint incident management teams, to commitments to support equitable access to COVID-19 vaccines. Countries in the region really have come together, born out of a recognition that no country is safe until every country is safe. Of course, none of things I have described are unique to the Western Pacific region, but they have come together this year in a unique way, sparing us from the scale of devastation from this virus that we are currently seeing in other parts of the world. But this is obviously no time to be complacent, as Angela also emphasized. The pandemic is far from over, and how it evolves in the next phase depends on our individual and collective action. So I'm very much looking forward to hearing from all our distinguished country representatives during today's forum. Thank you again for being here, and thank you very much. Angela, back to you.
Thank you very much, Adi. Thank you, both you and Professor Sachs, for framing the discussion that we're about to have, for setting the scene for our 2 panel discussions so nicely. So we're now going to go to the first of our panels, which is on the role of non-pharmaceutical interventions in suppressing transmission of the virus. On this panel, we are going to be joined by speakers from China, Singapore, Mongolia, the Republic of Korea, and Cambodia. And it's my very great pleasure to introduce our first speaker now. Professor George Gao is the director of China's Centers for Disease Control, and he's been an instrumental figure in China's response to the virus. So he's going to tell us more now about how China was able to contain and suppress the spread of COVID-19. Professor Gao, over to you.
Good morning. Good morning and good evening, everybody. as we already discussed, Dr. Sachs and Dr. Katai already mentioned, our region is the less affected region. And we are talking today something about the from containment to suppression or record mode. China is the only country, maybe in my opinion, who introduced the containment from the very beginning when we had this outbreak in Wuhan. So I'm going to talk about the NPI measures we did or we are doing in China from the containment to the suppression or record mode. Can I have the next slide, please? As you can see from here, in China, from this figure, it shows if it's in a blue column, it means that it's a local transmission. And if it is a yellow column, it means imported cases. After the first wave in Wuhan and in China, that's the Wuhan first wave. On my left panel of the right side, we have 40,000 deaths with 80,000, roughly 80 or 70,000 cases there. And after that, we have a lot of imported cases. We have encountered so far 8 local transmission, as you can see from that very small columns from the peak from the different regions. I'll come back to that later. Next slide, please. Let's come to the containment, what we have done. And how did China achieve the containment? Of course, it's very important. So whatever we are doing, it's interrupt transmission. What I would say, so when the West culture meets the East culture, so in my opinion, because we did very well for Dr. Fauci's 3W, wearing the mask, watching the distance, washing the hands. And this exactly summarized what we have done in China. I think it's so clear. Everybody knows, what we have done. Next slide, please. And this is the projection. So what we, from the science paper, they describe, in China with it's very important with the first 50 days. You look at the right figure. Without that containment, without the interruption, we have roughly at least 67 times more cases in China. You are talking about 100 more. But because of the containment, we did achieve such a great achievement because, we did this job. Next slide, please. And this is exactly the figure I copied from the science paper, how the non-pharmaceutical interventions achieved, in China. This will give you the number, tells you why we might have, from the projection, 67-fold more cases if we didn't do a good job. Next slide, please. Now, China, very quickly, we come to the so-called new normal situation. You can clearly see from the top panel of the right hand, you can see we already have a lot of get-together. One of them is we call the Golden Week. That is the 1st October, the National Day. We have 0.6 billion people, traveling around. This figure tells you one of the figures after Wuhan containment. We have a very big event in Qingdao. And you can clearly see from that, relatively normal. The lower left panel shows you the imported, the airport arrival in China, the increase a little bit. Right now, it's very steadily. But, we still, in general, like me, look at me, I'm on my way to a very important meeting. I'm on my way in my car, and you can see clearly, people cycling around. Most of them in Beijing, they still wear the mask. So that's very important. Next slide, please. Let me explain what we have done, what we have experienced in China. Look, left side, clearly you see, this is the Wuhan outbreak. So because of containment, we get that peak down. You have a peak, and then you have after the peak, you have that valley. And after that, next slide, please. Next slide, please. Yeah, can you press? Okay. And you can clearly see enlarged after the Wuhan, enlarge all these imported cases, but the number is so small. So I clearly, kind of show you this is all these numbers. The yellow one is the imported cases. The blue column is local transmission. Next slide, please. So after Wuhan containment, the first wave, we already experienced 8 waves. The second wave is in northeastern. Next slide, please. Press again. In the northeastern provinces, Heilongjiang and Jilin, you can see that very small peak there. And the third wave, next slide, please. You can press again. It's in Beijing, Xinfadi, also it's a seafood wholesale market. And then after Beijing, next slide, please. We have Urumqi in Xinjiang autonomous region. That's the 4th wave. Next slide, please. And mixed together, we have the 5th wave in Dali. Next slide, please. And then we have a very small one in Shanwei. Shanwei is somewhere, in Guangzhou, in Guangdong. So it's one single imported cases from Hong Kong. Then they, cause 8 more cases there. And then we have a 7th in Qingdao and 8th in Kashi. In total, we have all this is done. Why we define those as waves? Because we have already seen the local transmission for the peak, and also we have get all this down, see the valley. Peak valley interval is clear there. You can see. Because we did all this, we can find the place almost define the patient 0 and when it's introduced into the region. And also we did the sequencing. From a sequencing, we know the virus is special. Every single wave, the virus is special. Next slide, please. So for that, PCR testing screening is very, very important. From the outbreak, whenever we have something, we will start for the specific population, specific close contact, we do the PCR testing. We also will do the PCR testing for those region, the small region. You remember, even for Wuhan, we do the whole population in Wuhan, 9 million people for the PCR testing. That really works. We identified, though a very small number, in some cases, nothing, but that's very important. Next slide, please. So this is our plan. On the left column tells you, we define the different populations, the different situations, and what we should do. The star tells you that's a must. That's something must. Whenever you have the arrival airlines, we will have them quarantine for 14 days. During that 14 days, everybody must be tested from the day 0 and to day 14. That is very, very important. Next slide, please. This is what we are doing at the moment. So whack-a-mole or suppression. So PCR and case contact management, personal protection, social distancing measures, and travel-related measures, and also environmental measures. Next slide, please. This is my last slide. What I was asked by the Lancet Public Health. George, can you write something to summarize what's the most important part? In my opinion, most important part, go back to the community. Go back to the community. Don't give up. This is exactly what China is doing. So building up or stressing the public health at the community level is the key, not only for this COVID-19 control, but also for the great achievement for the last 70 years in China. For the life expectancy from 35 reached to 77.3. I will stop here. Thank you very much.
Thank you so much, Professor Gao. We can see that you're joining us from on the road, so thank you really for making the time to be with us this morning. I think your slide that showed without non-pharmaceutical interventions, there would have been at least 67 times more cases, really brings into very sharp focus the important role of these interventions in suppressing transmission of the virus. So thanks again for joining us. Next, we are going to go to Singapore. Our next panelist is Associate Professor Kenneth Mak. He is the Director of Medical Services in Singapore's Ministry of Health. Associate Professor Mak, I understand that you took up this post right at the beginning of this year. So I imagine it has been a whirlwind first 12 months in the job. Really happy to have you with us to hear more about Singapore's experience. Over to you.
Professor Jeffrey Sachs, Chair of the Lancet COVID-19 Commission, Dr. Takashi Kasai, Regional Director of WIPRO. Madam Moderator, ladies and gentlemen, the world has received good news these few weeks with several countries embarking on COVID-19 vaccine rollouts. While that brings hope as we near the end of 2020, it is incumbent on us as public health professionals to caution that having the vaccines does not equate to eradication of the disease and to urge continued discipline on non-pharmaceutical interventions as we move into 2021 and beyond. Vaccines are powerful medical tools to enhance our COVID-19 responses, but they alone will be insufficient. Singapore, an island city-state heavily reliant on trade and travel, indefinitely halting economic activities and closing our borders is untenable. Our economy is therefore dependent on whether we can successfully contain and suppress transmission successfully in the absence of vaccines. And in order to do so, the fundamental public health principles of timely testing, tracing, and isolation have remained a cornerstone, even as we adopt a risk-based approach towards reopening. We are detecting cases early through enhanced surveillance, such as using an expanded version of WHO's recommended suspect case definition, and testing all individuals with acute respiratory symptoms and pneumonia. We've also begun to conduct active surveillance testing on vulnerable populations, such as seniors in nursing homes, as well as potential vectors of spread, such as logistic workers, food handlers, stall holders, as well as living in dormitories. Once confirmed cases are identified, they are isolated and contact tracing is immediately conducted to identify close contacts. We have augmented our contact tracing efforts with technology, such as what we call the use of safe entry and trace together. Safe entry provides a record of locations where individuals have visited, as well as the length of time they spend in the particular area. And this allows us to do infectious individuals' activity map. To identify close contacts, especially in crowded urbanized areas, Trace Together, which was one of the world's first contact tracing mobile apps, was developed. It uses Bluetooth technology to estimate the proximity of individuals. And with the combined usage of safe entry and trace together, we have been able to reduce the time required for contact tracing from 3 days to less than a day for most cases. As Singapore is small and highly populated, testing, tracing, and isolation measures are important, but they're not entirely sufficient. We've striven to keep transmission rates low within the community by also keeping group sizes and gatherings small, ensuring safe distancing in public venues, requiring mask wearing for all persons who are at least 6 years old, and encouraging good personal hygiene. Singaporeans understand the rationale for these healthcare measures, which aim to safeguard not just themselves, but others as well. In addition, high public trust has provided us with valuable policy space to enact unpopular but essential social and movement restrictions. This has not been taken for granted by the government. We have endeavored to provide clear and consistent public communication. So for example, the co-chairs of our multi-ministry task force have held regular press briefings and kept the public informed of the latest COVID-19 situation and our measures since the pandemic started. All these have allowed Singapore to resume economic activities and to gradually reopen our borders. Based on the assessed risk, we have established different travel schemes which correspond to different health measures. We fully appreciate the uneasiness regarding border reopenings and risking community outbreaks, especially in countries and regions who have previously successfully contained transmission. Singapore is committed to working and sharing with fellow member states on best practices and guidelines so that we can resume our activities and reopen our borders safely together. Thank you.
Thank you so much, Associate Professor Mack. Many important points in those remarks. You mentioned the importance of public trust, and that's a theme that we will return to in our second panel a little bit later this morning. You also mentioned the importance of the multi-sectoral nature of the response, and that is a perfect segue to our next speaker. We are going now from the Malay Peninsula all the way north to Ulaanbaatar. Mongolia, from the very beginning of the outbreak, moved very, very quickly to set up its response based on years of preparation under APSED, the strategy that Dr. Kasai mentioned in his opening remarks. And as of today, Mongolia has recorded less than 1,000 confirmed cases of COVID-19 and 0 deaths. So to tell us more about Mongolia's approach, I am delighted now to introduce Professor Nyamku Duma, who is the Director General of Mongolia's National Center for Communicable Diseases. Professor Nyamku, over to you.
Thank you very much. Good morning, Honorable Regional Director Takashi Kasai and esteemed colleagues. For COVID response, Mongolia has taken early non-pharmaceutical interventions, including school closure, travel restrictions since January. Mongolia has experienced applying NPI during annual seasonal influenza outbreak, proactive school closure before the peak helped to slow down influenza transmission. Wearing mask has become daily routine since end of January. Good public compliance with wearing mask and hand hygiene has contributed to low incidence of infectious diseases. From 27 January 2020, social distancing measures have been taken. Schools shifted to online class and teleworking, mass gathering, public events banned, compulsory 2-week quarantine imposed. From April, NPI measures were gradually relaxed and businesses operated in a special regime. A strict lockdown imposed for capital city of Ulaanbaatar and 6 provinces when the first clusters identified in the community. Localized NPI measures were taken. Depending on the level of transmission, different measures were taken in provinces and even within the province. Ministry of Health has been preparing for the worst case scenario. Forecasting of estimated needs increased investment to health sector preparedness. There is modeling estimations show the effectiveness of NPI measures in suffering level of transmission.
Please go ahead, Professor Nyamku. We're having some trouble hearing you.
Yeah, just
Got you now. Go
sorry
ahead.
for.
Please go ahead when you're ready. Thank you.
It has nearly
Professor Nyamku, we're having some trouble hearing you. Are you okay to go ahead, or should we come back to you a little bit later in the panel?
Just second. One slide. доошоо ороход цаасан дээр яасан бол амар. Oh yes. Хаана. Алин дээр нь явж байгаа лээ. Одоо ингэ явчихлаа. Sorry for that.
No problem.
Continue.
Okay, whenever you're ready.
Thank you. Our government key response strategies are early detection, contact tracing, testing, isolation, quarantine, public communication, and community engagement. Resources dedicated to identifying and test all closer contacts. Contacting
We seem to have lost Professor Nyamku. I'm very sorry about that. We will try to reconnect him and perhaps come back to his presentation a little bit later in the panel, if that's possible. But while the team is trying to get in touch with him, let's now move to our next speaker.
For early detection of potential clusters. Multi-source surveillance and epidemic analysis tools developed by Wipro helped us to assess the true transmission level and increase level of confidence in monitoring the situation. Before COVID, we implemented NPI measures nationwide.
Apologies, we seem to be having some technical issues with connecting Professor Nyamku, so we will move to the next speaker now, but we will try to get in touch with him and see if we can hear the rest of his presentation at the end of the panel. So we're staying in the very cold part of our region now. From Ulaanbaatar, we're going over to Seoul and to the Republic of Korea. We learnt a lot from Korea early this year, as Dr. Kasai said in his opening remarks, about the importance of very, very quickly scaling up testing as part of the public health response. So today we are joined by Dr. Junwook Kwon. He is the director of the Korea National Institute of Health to talk more about Korea's approach. Dr. Kwon, over to you. Dr. Kwon, you seem to be muted. If you could unmute yourself so we can hear you, please.
Yeah. Dear Professor Sachs and Dr. Kasai and colleagues from the Western Pacific region, thank you for inviting me to speak on the topic today. Next slide. Although MPI plays a very important role in controlling COVID-19, considering of social consent, economic impact, and administrative and medical capacities, we have been carefully deciding on how and to which extent MPIs should be implemented. Today, I'm going to explain how and why these MPIs were used. Here, strong means measures that were regulated or enforced by law. Moderate means they were thoroughly guided and strongly encouraged by national leadership. Weak here means these measures were used in limited ways. Next slide, please. As with many other places, Korea experienced a shortage of masks. To ensure equitable distribution of the limited supply of masks to the public, export of certain medical and health-related products, including masks, were banned, and mask production, distribution, and sale were regulated. 5-day rotation face mask distribution system was used to reduce panic buying and ensure that everyone had a fair chance to buy masks. Local pharmacies were designated as channels for rationing these price-controlled masks for easy access and logistical infrastructure. With the system, everyone was ensured access to at least 2 face masks per week until the production caught up. Once there was enough supply of masks in the market to meet the demand at an affordable price, we gradually phased out the distribution system as it was no longer necessary. Failing to wear masks where it is required can result in a fine of up to approximately $92. Business owners are fined up to $2,700 upon violation within their premise. Next slide. Korea tried to keep its borders open during the past 12 months, even during the time of a big surge, with the exception of entry ban on foreign nationals from Hebei province implemented in response to the initial cases. To maintain this open border policy while keeping the nation safe, it was necessary to design and implement a strict border surveillance system. With a special entry procedure, all inbound travelers are tested twice. First within 3 days of entry and for a second time within 14 days after arrival. During these 14 days, they are required to quarantine either at home or at a facility. Based on regular risk assessment, travelers from some countries may need to meet additional requirements such as presenting an official proof of negative PCR test results prior to departure. Thanks to these strong measures, most of the important cases did not result in any significant further transmission. Next slide, please. Like incoming travelers, people identified as contacts of confirmed cases are subject to the government-managed home quarantine for 14 days. Each person under home quarantine is assigned to a local public health officer who monitors their health conditions and quarantine compliance either in person or remotely through a mobile application. Those who violate the guidelines may face up to 10 million Korean won or 1 year of imprisonment. For home quarantine assistance, local government sends each person a care package containing items such as food, masks, thermometer, and disinfectants. Next slide. Because of the multiple undesirable side effects of the social distancing, the level of implementation has been very carefully decided when levels are being shifted. This is, of course, conditional to the infection rate, but we make sure not to unnecessarily suffocate the social and economic activities. For more effective and practice guidance, the government of Korea revised to National Social Distancing Guidance System in June and November. These alert levels are applied nationwide with some level of discretion by local government based on local situation. The social distancing measure, however, has been implemented in a very moderate manner, allowing the business, restaurants, and shops to operate without ever shutting down since last January. Until today, we have not yet came to a full shutdown even at the regional level since the outbreak of COVID-19. Next slide, please. We also provide guidelines for public facility managers, business owners, faith communities, and public transport operators on maintaining their environment safe. Surfaces need to be cleaned and spaces fully ventilated at least twice a day. Hand sanitizers or disinfecting gels are to be provided in all the entrances, exits, and elevators. Stores that have been visited by confirmed cases are immediately disinfected following the guidelines. Next slide. In an effort to maintain openness and freedom of movement, including international exchange, Korea has mostly avoided closing its borders, except for limited cases as mentioned before. The only cases we restricted were the foreign nationals who are traveling from the Hebei province. All Korean nationals as well as foreign nationals were able to travel to and from Korea without much restrictions during the past 12 months. as long as the travelers fully abide with the requirements and guidance of the government. We are currently experiencing a sharp rise in COVID-19 cases locally as the social distancing level has been raised to the high level in Seoul metropolitan area. The government is advising residents to voluntarily stay home and avoid unnecessary travels. The travel restriction may be vital in controlling the disease, but in Korea, we used relatively soft measures so that we sustain the social and economic continuity while combating the disease. Last slide. This is all I have for today. Thank you for all your attention. Thank you very much.
Thank you very much, Dr. Kwon. Again, many interesting points in your presentation. It's easy to forget now that mask wearing is so ubiquitous in this part of the world, at least, that masks were in very short supply earlier in the year. So really interesting to hear about Korea's strategy for managing that problem, among many other points that you raised. It's now time to go to our last speaker in this first panel, and he's from Cambodia, which has to date recorded just over 360 cases of COVID-19 and, like Mongolia, 0 deaths. So to tell us more about Cambodia's response, and again, to talk about this issue of multisectoralism, the importance of the multisectoral nature of the response, it's my great pleasure to introduce Dr. Kim Cheng Hock. He is the Director General for Health in Cambodia's Ministry for Health. Dr. Hock, over to you.
Good morning, Chair. Good morning, Regional Director Wipro. Ladies and gentlemen, the first COVID-19 case in Cambodia was diagnosed on 27 January 2020, and the second case was diagnosed on 6 March. The Royal Government of Cambodia responded early and rapidly to the first case by implementing the nationwide non-pharmaceutical measure before COVID-19 could spread in the population. This strong leadership and quick decision proved individual in the early day. I would like to highlight the commitment of the highest level of the Royal Government of Cambodia, including the National Committee, the Interministerial Committee, the Provincial Committee to respond to the COVID-19. Another element is the good multi-sectoral cooperation and public-private partnership in Cambodia. This measure, including closure all education facility, issuing travel restriction internationally from the country with large-scale transmission, and temporarily between the province in Cambodia, limit on mass gathering and postponement of the Khmer New Year holiday in April. Notably, there was never been a lockdown in Cambodia. Additionally, our experience during the previous pandemic, including SARS in 2003 and H1N1 pandemic in 2009, had sensitized the population who were accustomed the wearing masks and physical distancing. These measures were widely adopted in Cambodia without any resistance. As a result of this measure, Cambodia was able to remain in the stage 1 with no localized transmission despite several important events. By mid-April, many of restrictions were lifted, although risk communication messaging encouraged the use of mask wearing and social distancing, the so-called new normal. In May, screening and mandatory 14-day quarantine was introduced in the new arrival at all the points of entry. Cambodia used the 3-stage approach. Until November, we had remained in stage 1, but due to the recent localized cluster, we are currently in the stage 2. Early detection and rapid containment response with target national non-pharmaceutical intervention aimed to prevent large-scale community transmission. Even so, while responding to the current cluster, we continue to invest in preparedness for the community transmission, focusing on all 25 provinces. Currently, Cambodia is using more target NPI. For example, schools were closed, the mass gathering ban only in the target city of Phnom Penh and Siem Reap. The rest of country continue living in new normal. In response to every single case, the Cambodia Ministry of Health undertake aggressive testing, contact tracing, and quarantine alongside target NPI. This has ensured that Cambodia remain ahead of the curve and prevent widespread community transmission. Such risk-based approach are essential to strike a balance between the health and social economic impact of COVID-19. Finally, we have to recognize the importance of individual behavior and community participation to comply with the recommendation NPI. Without this, we cannot successfully achieve suppression of transmission. In summary, Cambodia successful suppression of COVID-19 to date can be attributed to the combination of strategy of which NPI play a significant role. Thank you very much for your attention.
Thank you so much, Dr. Hock, for rounding off that first panel so well with Cambodia's experience. Before we go to the next panel, I'd like now to call on my colleague, Dr. Huong Tran. She is the Director for Disease Control here at the Western Pacific Regional Office of WHO to provide some reflections and responses to that first set of remarks. Dr. Huong, over to you.
Thank you very much, Angela. Good morning, good afternoon, distinguished participants. First of all, I would like to start with my great appreciation to all the speakers, as each of you provides us with invaluable learning opportunities from your country experience. Learning from real-world events for continuing improvements has been our culture in the Western Pacific region. From today's brief but rich and thoughtful discussion, one common theme for all the countries is early detection, rapid response, and targeted intervention, which serve as the common COVID-19 response strategy. While each country is unique and different, both in terms of the country context and its experience of the outbreak, clearly the implementation of NPI has played a critical role in suppressing the transmission. Throughout the presentation, we have seen common success factors on the role of NPI in suppressing transmission. For example, the strong policy in place for quick and strict containment strategy, applying non-pharmaceutical intervention in suppressing the transmission from very beginning of the pandemic has been shared by China. The decision based on clear steps informed by the best available information and risk assessment. The joint decision making and the whole of the government and multi-sectoral collaboration are so important in outbreak situation. Singapore, Mongolia, and Cambodia was a great example of how this works in practice. NPI has been also enforced and supported by regulation and legal framework. The Republic of Korea experience is a clear illustration of the regulation enforcement taken in place to implement the NPI. The phased implementation of control measures, both gradually relaxation as well as the availability to scale up and down depending on the epidemic situation. It was very interesting point from Singapore and Cambodia remarks. The protection of vulnerable population, we have seen how this virus preys on the most vulnerable and they must be ones on the forefront of this response. I thought Singapore intervention was very important reflection on this, how to focus on vulnerable population. And I think we saw in all the presentation how countries are adapting differently to the new normal, where health and economy go hand in hand, and where individual actions are understood to be foundation. And for collective health, in this new normal, we all need to think less about ourselves and more about how our actions affect others. And some other important themes from the panelists' excellent remarks are, first, clearly the past investment in core public health system capacity and pandemic preparedness has paid off. As our regional director mentioned earlier, countries in the region has been preparing for an event just like this one for more than a decade. And so they are ready to switch on when the pandemic hit. The importance of early detection and rapid response to contain the spread, even when there are only a small number of cases. This is a necessary precondition for the successful implementation of NPI. So once again, thank you very much for all the speakers for your excellent remark and presentation. I'm back to Angela. Thank you.
Thank you so much, Dr. Huang. We are now going to move to our second panel discussion on the very important set of issues around establishing and sustaining social norms around those very important protective behaviours, mask wearing, hand washing, etc., as well as the important issue of building community support for the broad range of public health measures, including MPIs, that we know are so important to suppressing transmission of this virus. So we are going to be joined by speakers from Fiji, Vietnam, Australia, Japan, the Cook Islands and New Zealand. To start us off, I'm delighted to introduce our first speaker in this panel, Dr. Ifirame Wanganabete. He is a surgeon, he's a clinical leader, he's also the Minister of Health and Medical Services in Fiji, and he joins us today despite the fact that there is a Category 5 tropical cyclone heading towards Fiji as we speak. So we're really, really happy to have you with us, Minister. Thank you so much for making the time. Over to you.
Thank you very much, and thank you for this opportunity to address the panel. And as you rightly said, Category 5 cyclone that's just beginning to make landfall in the country. Again, just brings to the fore the importance of pushing and advocating for climate change, because we're seeing these super storms coming our way. We cannot change our coordinates, and that's where we are.
We're having trouble hearing you. Could you speak a little louder, please? The audio is not great. You could speak a bit louder, that would be great.
Thank you. Can you hear me?
Better, thank you.
Thank you. As you rightfully said, we are at the moment, we have a super cyclone with Category 5 just beginning to make landfall on the other side of the island. And we cannot advocate more stronger for climate change that we need to be able to push, because we're beginning to see more and more of this continue to affect the Pacific. I'd like to thank you for this opportunity to talk about what we are doing in Fiji, and on the topic of establishing and sustaining social norms around individual protective behaviors and community support for public health measures. Next slide. Next slide. As of last Thursday, we are now nearly 250 days since we had our last case outside border quarantine. We've had 46 cases, out of which 4 were currently active. I hear there's now only 2 that are currently active. There were 2 deaths, but these were border quarantine cases. There were people that came back to Fiji with COVID-19 and they passed away while still border quarantine. We have done nearly 20,000 RT-PCR tests. And if we look back at our first 18 cases that were in the community, we know they were not really a community transmission, because the first 6 cases, the other 12 were actually happenings related to the first 6 cases. And we know that we've had a very strong containment effort. And in the midst of that, we also had a tropical cyclone. So I'd like to talk about what is so important as we move forward and continue to manage social norms. Next slide. one of the important things is actually making sure that we have our legislation and policies in place. So these were bills and amendments, initially bills, but then became acts. There were amendments to the current acts that we have through the Public Health Act, which is a long-standing act since 1936, and has undergone continuous amendments, including the COVID-19 amendment that was done, and also the Quarantine Act of 1965, which is also had an amendment done. So what the amendments have done is to recognize COVID-19 as a new infectious disease. It allows the suspected cases to be quarantined. It gives power to the minister, permanent secretary, to control public movement with lockdowns and curfews, and the power to enforce social standing. So I think the first important thing that we've been able to do, I think is important, in being able to push out a change in a social law, is actually having the political will and the legislative will to do. Two, as Martin Luther King Jr. said, a genuine leader is not a searcher of consensus, but a molder of consensus. And we've been very fortunate that we have an honorable Prime Minister who's very decisive. Just last week, our honorable Prime Minister was awarded the Champion of the Earth award for his leadership in climate change. But it's also a cabinet with the whole head of government commitment, together with the whole of government leading the way, the whole of society approach, which helped with the successful containment of our first episode of community cases. One of the things that we did very early was when we had the first 6 cases and with the epileaks of 12, and then we contained them with lockdowns in the 2 cities, we also did within 2 weeks a massive community fever screening exercise in which we community fever screened 850,000 of our 880,000 population. And thirdly, is gaining the community trust in the health system, government, and growing with religious leaders, village chiefs, and workplace managers. The UN resident coordinator said it is very good to have effective decisive leadership, but also what has actually worked very well also for Fiji was the fact that the community listened and heeded advice. And this happened because we had community health workers on the ground, we had zone teams on the ground, we were working with other stakeholders on the ground, gaining their trust so they could listen to what the advice that we were giving. Next slide. Next slide. Also of importance is the risk communications. Information to the public has to be transparent and timely, which prevents panic and blocks out misinformation. The Director General of WHO talked about this in the disinformation that existed in the early parts of the COVID-19 pandemic throughout the world. And this is something that every country, I believe, had to deal with the misinformation and the use of social media for those who are not patriotic to the belief and to the values that were being put out in terms of creating panic and misinformation. And I think it's important to be timely and to be transparent. Developing a comprehensive communication plan and communication package with clear behavioral output and to develop a behavioral change. And as I've alluded to earlier, we used our community health workers of more than 1,600 together with the district advisory councillors, which are another 1,000, working with those on the ground. We have 240 facilities in our more than 100 islands that are inhabited, and actually just working through these mechanisms of government and CSOs to be able to take the message out to the community. And we reached 100% of all communities in Fiji in our community communications around COVID-19. So once we've done that, we've created that containment, we sealed it off. We know that we've got very strong processes around border quarantine cases. And as a country, we believe that we have a duty of care to allow our citizens to come back to Fiji, and we opened out our borders to be able to have repatriation flights. Therefore, we had border quarantine cases, including the 2 that did pass on. We also made sure that we had a framework, a plan of safe economic recovery framework. And this is to ensure that we stimulate our economic recovery. We are a country that about 30% of our GDP is dependent on the tourism industry. 40% of our GDP is dependent on the tourism industry. And finding ways in which we can be able to support economic recovery. So we opened COVID-safe travel bubbles, pathways. We had a committee which was high level, which was run by the permanent secretaries or the chief executive officers of the ministries. So we allowed about 92 yachts to come through just before the cyclone season, and that was able to allow us to have some income generated. We also have the Vacation in Paradise Day, which is ongoing, and we're working with Australia and New Zealand, hoping to develop a travel bubble with them. And also, we are also talking to other Pacific Island countries in regards to the Pacific bubble. As you're aware, some of those countries are still COVID-19 and haven't had the first case of COVID-19. This slide. And once we did that, we pivoted. We pivoted by remodeling our health service provision so that we can carry on supporting the social norm, the new social norm post-COVID era. We modeled so that we are more integrated and we inserted it into our annual operation plan. So it's not a one-off thing. We've said to ourselves, this is going to be how we're going to function from now on, which has become very useful because that remodeling has, when this cyclone has come upon us within the last 2 days, we just re-stratified and re-strategized our command centers that we have for COVID-19 into tropical cyclone command centers. So the key components of our remodeling is establishing and empowering divisional, decentralized centers with better coordination and support, integrating the health services, so clinical services and public health services work together, and discouraging silo longitudinal models of service, strengthening our health information system communication with a huge push out of a digital platform, working with digital Fiji and strengthening and integrating disease surveillance capabilities. Those are our ministry's thoughts around that topic, and I thank you and I wish you all the best in this discussion.
Thank you so much, Minister Wanga. Really, really appreciate you making the time to be with us today and for that excellent overview of Fiji's response. Please take care and stay safe in the coming days as that cyclone heads towards you. We'll be thinking of you. Next, we go to Vietnam. We're joined from Vietnam by Dr. Dang Quang Tan. He is the Director General of the General Department of Preventative Medicine in Vietnam's Ministry of Health. Dr. Dang, we're really looking forward to hearing more about Vietnam's response. Over to you to tell us more. Microphone is off. We can't hear you. Could you try unmuting yourself, please? And turn on your camera. We also can't see you. Bear with us for a few moments while we try to find Dr. Dang. Dr. Dang in Vietnam, are you there? Can you turn your camera and sound on, please? Okay, while we're trying to find our speaker from Vietnam, we seem to be having some technical issues connecting with Vietnam. We will go to our next speaker, who joins us from Australia. I'm really delighted to introduce Professor Brendan Murphy. Brendan is the Secretary of Australia's Health Department in my home country, but for the first 6 months of this year, he was the Chief Medical Officer of Australia and provided both the clinical leadership of Australia's response, but was also the public face of this issue in the Australian media. So it's really great to see you, Brendan. Thanks so much for taking the time to join us. Over to you.
Thanks, Angela, and thanks to Wipro for organising this session. So the Australian situation, we're in a very nice position at the moment where we have essentially controlled community transmission, or really got rid of community transmission, with some small outbreaks appearing from time to time, almost always associated with return travellers and some breaches of our quarantine situation. So our strategy right throughout this pandemic, from the outset, we decided we would not be prepared to accept ongoing community transmission. So, but on the other hand, we also took a view that we had to be proportionate in our responses. So we did take advantage of our island status early on and introduced fairly significant border measures, and were able in that circumstance to control importation and take the community with us. We set up a whole new structure called the National Cabinet because we are a federation and each of our state and territories have responsibility for the public health response. So we had to get consensus views on how we brought restriction measures in early on. And we had very good buy-in from the public. We took a view that we would communicate often and transparently and be very clear about what we didn't know. And we had a very good early response with controlling importation and distancing. And that gave us the capacity to build up and scale up our public health response. We also took a view early on that at no stage would we ever give up on active and aggressive contact tracing and quarantine and isolation measures. The only time where that's fallen over was in the state of Victoria in its second wave in the middle of the year, which was probably our most unfortunate outbreak, and that really contributed to 20,000 of our 28,000 cases. And that was really due to the one situation where we failed in our public health response. So whilst we've taken the view that social norms around individual behaviours and proper behavioural changes amongst the public are important, they are never enough unless you've got really, really good public health response capacity. So we've scaled them up in every state and territory to the point where we know that unless we got a situation of several hundred cases a day, we would be able to fully identify and isolate all contacts of cases. And that's what we've been doing really since we controlled the Victorian second wave. We have had really whack-a-mole type approaches to a series of small outbreaks that have appeared. What we have seen though is that some parts of the country where we've really had no community transmission for several months, it has been very difficult to maintain those social norms, and particularly Western Australia, which is quite isolated geographically and have taken a very aggressive internal border measure. They've essentially, for most of the last few months, they've adopted a normalisation of community behaviour, and so they had full stadiums at their sporting matches. They weren't doing much in the way of distancing in social venues and weren't even recording venue information for guests. And we've worked with them, and they're now moving because they recognise, having seen what's happened with some of these quarantine breaches in other parts of the countries, that an outbreak can occur incredibly quickly. We just saw in South Australia, one breach in a hotel quarantine worker led to an outbreak of 20 cases, which was rapidly controlled. And that's what happened in Victoria when it wasn't controlled. So we are in this situation of a nice balance, but the community is quite anxious about some of the overreactive behaviour of some of our public health officials, because there is now watching what's happening in the Northern Hemisphere at the moment, there is extraordinary anxiety. And for example, at the moment, there are 4 new cases in Sydney, New South Wales today. And that's the top news story across the country. And and there will be some people in the public health world who would like to introduce measures beyond just aggressively isolating and contact tracing, which the New South Wales Health won't do because they are very proportionate in our response. So we've had to keep that proportionality going and bring the population with us. There is a lot of hype now about vaccines and, why aren't we rushing into getting vaccines under emergency use authorisation? Our narrative with the public has been, well, we're in a good position, we can wait. We don't have to go through emergency authorisation. We can go through our normal regulatory approach. And we can also benefit from the early experience of the UK and the US in rolling out vaccines. So we have had a really good success story, but I would say that not one part of the response can be weak. So we have to have good social norms. We have to have good ways of, when we open up the economy, of capturing the people who are in and out of venues. And we have to continue, we have in most parts of the country continued, ongoing working from home for a lot of people. Public transport is still, significantly below capacity. Mask wearing is quite widespread in some parts where there were outbreaks, so in Victoria and a bit in New South Wales, but less so in other parts of the country. And we have taken the view that the most important thing at the moment now is to maintain our high testing rate, which is also a challenge, and to make sure that we very, very quickly and aggressively respond to any outbreaks. So I think I might sort of leave it there, Angela, and obviously happy to respond to any questions.
Thank you so much, Brendan. And I should say that actually the idea for today's forum came from Brendan. So thank you for that, as well as for those excellent remarks on Australia's response. So many important points in that, but I think your point about maintaining a sense of proportionality depending on where a country is at in its stage of the outbreak is a really important one for us to think about. So thank you very much, Brendan. From Canberra, we now go to Tokyo, where we are joined by Dr. Yasumasa Fukushima. He is the Vice Minister for Health and Chief Global Health Officer in Japan's Ministry of Health, Labour and Welfare. We heard from Dr. Kasai earlier about the importance of Japan's famous 3 Cs. So to hear more about this and about Japan's response, over to you, Dr. Fukushima.
Thank you, Dr. Angela. Good morning. I am Dr. Yasumasa Fukushima, Vice Minister for Health, Chief Medical and Global Health Officer of the Ministry of Health, Labour and Welfare of Japan. I would like to thank our hosts, the COVID-19 Lancet Commission and the WHO Regional Office of the Western Pacific for inviting me today. I'm delighted to share our experiences with you. I would like to talk about the 3 key messages that Japan has established to encourage behavioral change and sustain social norms. First is to avoid 3C environments. In Japan, there was already a strong awareness of public hygiene before the COVID-19 pandemic. Many Japanese wear masks during the flu season and wash hands frequently. And therefore, those habits soon became widespread. To promote further behavioral changes, we spread the messages to avoid 3C environments, which are closed spaces, crowded places, and close contact settings. These 3 Cs are a common environment that cluster occur. We use the word 3 Cs constantly as part of our country's effort to prevent the spread of the virus. Since March, the avoidance of the 3 C's has been broadly used in public communication to prevent COVID-19 transmission, and this message has widely reached the general public. Accordingly, 3 C's was Japan's top buzzword for this year. Second message is to avoid 5 specific situations with a higher risk of infection. First, social gathering with drinking alcohol. Second, eating and drinking in a large number of people for a long time. Third, conversation without masks. Fourth, living together in a small communal space. And lastly, changing location to task break or relax. To promote behavioral changes, it is necessary to disseminate a clear, concise, and easy to understand message, such as to avoid 3 C's environment and 5 stations. Free posters of these critical messages are available on our website, which people can use all offices, schools, and places where people gather around. Our third message aims to show gratitude. We launched a new interactive project this month with the private sector to comprehensively prevent transmission and discrimination linked to COVID-19. In Japan, patients, healthcare workers, and their families are facing harassment and bullying related to COVID-19. The project highlights the importance of preventing infection and showing gratitude to essential workers. We are sharing the hashtag Let's Express Our Thanks through our health ministry supporting organizations and individual social media accounts. By spreading empathy and encouragement, we aim to create an inclusive society that combats infectious disease. Next, I would like to talk about our support for vulnerable communities in Japan. To facilitate access to testing and treatment, it is essential to engage local communities, including foreign residents. Regarding support for foreign residents in Japan, we were highly depending on local resources and volunteers for medical interpreters and disseminating information in multiple languages. Therefore, in addition to cooperating with embassies and local governments, we are now enhancing relationship with international exchanges, associations, non-profits, and NGOs that have networks and working experiences with these committees to ensure a better understanding to COVID-19 measures. Our ministry is strengthening communication with foreign residents to inform them how to receive medical care. We have created a website in multiple languages, which includes information on how to consult with a doctor when suspected infection occurs. We also created leaflets and posters with QR codes that connect to website prepared in 11 languages, including English, Chinese, Korean, Vietnamese, and Tagalog. To conclude, we are deeply grateful for the regional director, Dr. Takeshi Kasai's leadership in tackling the COVID-19 pandemic. Our region has been able to prevent devastating consequences of uncontrolled COVID-19 pandemics compared to other regions. Sharing experience and information within our region, as well as outside of our region, is vital for infectious disease control, which easily cross-border. Japan would continue to cooperate with the global community to fight against COVID-19. Thank you for your kind attention. Thank you.
Thank you very much, Dr. Fukushima. Now we are heading back to the Pacific and specifically to the Cook Islands, where we are joined by Dr. Omiya Herman, who's the Permanent Secretary of the Cook Islands Ministry of Health. The Cook Islands is one of the very few countries in the world which has not recorded a single case of COVID. So Omiya, you have a very different set of challenges in maintaining public support for public health measures to keep it that way. So we're really, really happy to have you with us here today. Over to you.
Thank you very much, and kia ora to all our colleagues, Professor Sachs, as well as our RD, Dr. Kasai. Next slide, please. So I think, as with many other countries around the world, when the COVID came on, everyone hit into top gear in terms of developing a response plan. And similarly for the Cook Islands, we had a pandemic plan, but had never, influenza pandemic plan, but had never thought about COVID. So it was an interesting experience for us to prepare for this. Next slide. I think one of the big things for us was really around leadership and governance in the Cook Islands, starting with the Queen's representative, Prime Minister, down to Cabinet, and then other agencies that were in operation, the National Health Emergency Task Force. But I've circled here in red, in particular, two strong pillars of the community. So you've got government, then the other two are what we call the House of Ariki or Arungamana or traditional chiefs. And then of course we had the Religious Advisory Council. These are the three pillars of our society, and they were involved in throughout this whole process. We also included the NGOs, the district areas, both in Rarotonga, the main island, as well as the other outer islands of the Cook Islands. We had our international partners working with us, as well as the private sector and other government agencies. Next slide. In terms of the structure, you can see here, this is November 2020. I started this role about just over 2.5 years ago. And one of the key things we did was to restructure the organization to make it much more flat, as well as inclusive in its decision-making processes. So you can see here circled firstly the community health settings services, where we had public health, oral health, primary care. Primary care is brand new for the Cook Islands Ministry of Health. This has not really, it's been absorbed into hospital health services. The other thing that's right at the bottom is mental health sitting under public health. Now this has been our process in terms of cocooning mental health, growing its capacity, and we're hoping in the next 1.5 to 2 years, we can bring that out as a separate directorate. And all of these, without us realizing, because it started at the end of 2018, all of these processes we were putting in the restructure really prepared us, not well, but close to well, for COVID-19 and its arrival. The other thing I want to point out over here is on the other part of the screen, on your, might be your left hand, with advisory committees, where we had the Community Health Advisory Committee in Rarotonga, as well as the Paenua or Outer Islands. This was fundamental because we've had this around for some time, but when I started work for the past 2 years, we've been having regular meetings 4 times a year, and they have been instrumental in terms of giving us advice about things that they see on the ground that the Ministry of Health could improve on. So having these two set up as we entered COVID times was really instrumental in assisting us connecting with our community and listening to their thoughts on how we should do better or how we could do better. I wanted just to point out as well, just before Community Health Advisory Committee is the Traditional Medicine Committee, and there was work in progress in 2018 and the end of 2019, but in 2020 this has taken a bit of gone a bit slow, and hopefully in times ahead we will continue to progress this, because I do believe that this is an important aspect of ensuring conventional and traditional medicine work together. Next slide. So in terms of community engagement and assisting the establishment of social norms and so forth, I've highlighted a few key strategies that the Cook Islands Ministry of Health took. Border restrictions were the first and foremost for most Pacific Island countries, and many are still holding these very strongly, including the Cook Islands. However, we've reached a point where we are now able to have quarantine-free travel into the Cook Islands, but only restricted to Cook Islanders and permit holders, as well as those coming from New Zealand. The point being that you must be in New Zealand at least for 14 days before you can come into the Cook Islands. And this has been important in terms of allowing us to continue to have our families move across countries. As you know, we are New Zealand citizens, and so we also have some pressures on our health system in terms of the referrals of patients back to New Zealand for tertiary level care. Surveillance and testing regimes that we have shifted along the way have also helped in terms of informing our border restrictions. I've reflected here again what I've shown before in the other slide around the organization and the restructure. This was critical. So we were shifting resources to community settings. That was fundamental in what we did, because in entering the Ministry of Health, what was very clear was that the hospital was soaking up all our resources, and yet we know that primary care prevention is the cornerstone of all health systems. So by shifting, by restructuring our organization, the focus moved to primary care, preventative medicine, and services being placed much closer to and within our communities. And this also happened in terms of the decentralization of our health system. COVID-19 really accelerated our plans to focus on primary care and preventative medicine, and really looking essentially for universal health coverage. So what we did was outpatients and emergency services that were traditionally up at the hospital were shifted to community settings, and then we established 10 community health clinics in each of the districts on Rarotonga. We already have these smaller clinics available in the outer islands, so Rarotonga was the main place for us to establish. In terms of setting up the community health clinics, though, this was working in close partnership with the district leads or the community leads. And in terms of supporting this further, we formalized partnerships with the community health clinic leads in terms of embedding and continuing to support this. Last slide. And I think in terms of risk communications, community engagement, this has been the cornerstone of our work with the community and how we've taken our people with us. The IPC work that we did, this was fundamental right from day one in terms of doing all the right things, cough etiquette and so forth. A really important one for us was around the singing in churches. As you know, many Pacific Island countries and other parts of the world do churches are very important in terms of holding communities and that social cohesion, and trying to advise our people that singing might not be such a good thing was difficult. But more recently we've promoted face masks much more wider this time, and we're hoping that our local tailors can do this for us. I wanted to highlight, though, the other part around this in terms of the influenza vaccine, where we've managed to achieve 33% coverage in the Cook Islands, which is a very important factor given what we know about any kind of vaccine helping the immune system and also protecting against COVID. But the fundamental part around this was to make sure that we could at least take influenza off the table, and we could probably have a better line of sight to COVID coming our way. Supervised quarantine, of course, has been an important one for us with our border measures and lifting of border restrictions. And the 24/7 security was provided by the district or the communities, and we gave them a small fee for doing this. And these are some of the partnerships that we did and continue to do to make sure that we continue to work with our people and listen to their thoughts. And I think one of the big things for us was that the easy one for us would have been to put everyone coming in from overseas into a hotel. But what we thought about in the longer term was that we needed to teach our people how to look after themselves. And one way is to involve them in all these work plans. So that has been very important. Lastly, vaccine rollout. We've again engaged with our community leads, and we do this every week. We speak to Rarotonga once a week, and then on the same day we speak to the outer islands. And this has been fundamental in terms of alerting them to, or advising them, or updating them on the work that we have done, what's happening overseas, and where to into the future. So vaccine rollout discussions have now begun. We have a plan that needs to be finalized. And so these are some of the things that we've done in terms of taking our people with us and helping them inform our processes and improving them as well. Thank you very much.
Thank you so much, Omiya. It's really great to have you with us, and incredibly impressive to hear about all of that work in the Cook Islands, bringing the community with you, as you say, even in the context of not having any confirmed cases of COVID-19. So thanks very much for being here to share your experience. Before we leave the Pacific, we are now going to New Zealand, another country which has had extraordinary success in suppressing transmission of the virus, in fact, effectively eliminating COVID-19 from New Zealand. To tell us more about this, we are joined by Dr. Ian Town. He is the Chief Science Advisor in New Zealand's Ministry of Health. Ian, over to you.
Well, greetings, colleagues, and I'd like to acknowledge our co-chairs, Professor Sachs and Dr. Kasai, along with colleagues from around the region, and thank the WHO Regional Office for organising this excellent presentation. It's very humbling to hear how so many countries have worked cooperatively to combat this terrible pandemic. If I could have the next slide, this will show the time course of the epidemiology here in New Zealand. We did have an imported case in March, and as you can see, in April, had a real surge of cases here in New Zealand, starting with imported cases and then moving to quite significant community transmission during April. As has been noted, we managed to eliminate community transmission towards the middle of May and had over 100 days of no new community cases. From that point on, we managed the border very tightly. And then, as you can see, we had a little blip in mid-August. An incursion occurred, we think, through a breach in managed quarantine facilities, and that led to a small but significant outbreak in South Auckland, our largest city. Since then, all of the cases that have been identified in managed quarantine facilities, which are being managed throughout New Zealand in a number of hotel facilities. The next slide, please. This slide describes simply our elimination strategy and echoes the approach that many of you have taken around the region. We have focused as a small island nation on border management as our primary protection, and then, as many of you have, to identify through tracing and identifying through testing and tracing, the cases and incursions and stamping out those small outbreaks. Our disease surveillance and testing has ramped up increasingly, and we've got smarter and smarter and a lot faster at identifying community transmission and identifying those cases who need to be put into isolation awaiting tests. So in terms of the wider public health measures, we've been very fortunate to have excellent communication from our political leaders and from our Director General of Health, Dr. Ashley Bloomfield. The next slide shows our alert levels, which bear a remarkable similarity to those adopted throughout the region. I think ours was originally based on colleagues from Singapore who described these levels of public health responses. We are currently in level 1, but as you're aware, we moved very quickly. Our Prime Minister coined the term go hard, go early, and we moved in March quite quickly from level 2 through to level 3 and then a few days later to level 4, which was a very tightly controlled set of measures to have people staying at home and not moving about the country at all. So amongst some of the strictest measures that have been invoked around the region. While I'm on this slide, it enables me to illustrate some of the imagery and some of the ways in which the government communicated. The Unite Against COVID-19 really invoked our very strong national identity, brought together what was termed the team of 5 million, which is our entire population, working together to protect each other and protect the community, and added to that also a strong message to look out for one another. Be kind was one of the strong messages from our Prime Minister. The next slide just captures some of the images, and there again, the Unite Against COVID-19. That brand was used throughout the campaign and continues to be used today on television, on posters and billboards, and through a variety of social media outlets. It has been extremely well organised, tightly managed through communication channels, and I think has brought everyone together in that unite message. Our Prime Minister, the Right Honourable Jacinda Ardern, visited the Ministry of Health yesterday to thank us for the work we've undertaken here in New Zealand. But as you may recall, in New Zealand, we had what was called a stand-up, which was a media conference virtually every day for week after week, which was led jointly by the Director General of Health, Dr. Ashley Bloomfield, and the Prime Minister or one of her senior ministerial colleagues. And you can see here she's holding up a cartoon of the message early on, which was to flatten the curve and prevent the overwhelming of our health system. As you're probably aware, we've only had 2,100 cases here in New Zealand, and although very sad to have 25 deaths, a very small number affected in that way. So I think in summary, we've had a united population, strong, consistent messages from our government and the Director General of Health, and a team of 5 million, which has been that uniting concept. At the moment, we are on the threshold of learning more about our vaccine program, and with some initial announcements made by the Prime Minister earlier today. But in conjunction with colleagues in Australia and then the wider Pacific, we're planning an immunisation program here in New Zealand, which will start towards the end of the first quarter or early in the second quarter in 2021. We do accept that our borders will remain closed, and I guess as a small island nation, very remote, we've had the opportunity to keep our borders tightly closed. Our biggest concern at the moment actually is probably going to be complacency. We haven't had much community transmission recently. We have an extended summer break, which is approaching rapidly, and New Zealanders traditionally travel widely through that period, visiting family and friends and enjoying a variety of activities. So we are just launching a new campaign here in New Zealand directed at keeping people safe over the summer period and ensuring that they maintain those very basic but important practices, such as staying home if you're unwell, washing hands, and managing with cough and sneeze etiquette. So that in summary is how New Zealand has engendered quite strong social license. We hope it can be maintained, and we're very grateful for all the advice and collegiality we've had from members around the Pacific region. Thank you very much.
Thank you so much, Ian, both for so eloquently explaining the importance of that, the communication and engagement piece, but also reminding all of us to guard against complacency in all of this. I agree with you that that is one of our most dangerous enemies at this stage of the pandemic. We have, I think, been able to connect Vietnam again now. We had some issues earlier, but I believe our colleagues from Vietnam are now online. So it's now my pleasure to round off this panel to go back to Dr. Dang Quang Tan, the Director General of the General Department of Preventative Medicine in Vietnam's Ministry of Health. Dr. Dang, over to you.
Thank you very much. And I would like to say sorry because I have firstly technical connection. So now it's very good. Can you hear me? Excuse me?
Yes, go ahead.
Yeah, thank you. Dear Madam Chairwoman, Dr. Takashi Kasai, Regional Director, distinguished guests, ladies and gentlemen, a very good morning. First of all, Vietnam would like to thank the Lancet COVID-19 Commission for your organizing this virtual forum for country in the WIPRO to share COVID-19 lessons learned from containment to suppression. As you know, at the beginning of the COVID-19 outbreak in 2019, Vietnam well recognized as a country with high risk of being attacked by the disease. Therefore, we think that if the epidemic occurred, it could greatly affect the social security and on the people of Vietnam and cause overload of the whole health system. Under active direction of the party and state government, Vietnam has mobilized the entire political system and the participation of people in COVID-19 epidemic prevention activities. Proactive and early implementation of epidemic prevention and response activities at the beginning of January 2020, we implement very early. So that would help to limit the entry of COVID-19 from foreign countries into Vietnam, as well as slow down transmission of the disease in our community. Vietnam has basically controlled the epidemic of COVID-19 in the country so far. However, in some certain time, we recorded known of infected case in community for a long time period. For example, we had a period of 3 months without no case in community. The most recent outbreak of a home quarantine case detected on November 30th has been truly contained. As of December the 2nd this year, no new case has been recorded in community. And so far in Vietnam, we have a totally 1,400 confirmed cases of COVID-19 in Vietnam, including 35 deaths. This has created social economic stability and ensure national health security. Ladies and gentlemen, in the previous time, Vietnam has persistently implemented 4 strategies. Firstly, prevention from outside. Secondly, early detection. The third one, quarantine. And the fourth one, that is the effective treatment for all cases. Accordingly, there has been strict application of key outbreak response measures. For example, we conducted strict surveillance and detection at point of entry. At point of entry, we apply health declaration with 5 languages. We also close quarantine of on passengers returning from epidemic areas, establishment of zone control at the outbreak, even that we lock down an area, even we lock whole city, for example, in Da Nang city and in the central of Vietnam. Contact tracing with those who has close contact as well as on people with close contact, and monitoring health status of other relevant people. Hospitalization, home quarantine, screening, tests, and treatment for all confirmed and suspicious cases. Communication activities has been widely implemented in Vietnam in all mass media, updating current situation of the outbreak and providing recommendation messages and policy in prevention and control of the COVID-19 by our government. Vietnam has also been active in research and manufacture of the diagnostics bioproduct. And you know that we are now currently conducting a research on production of vaccine for COVID-19. Duration of COVID-19 prevention and control Vietnam regularly exchange and update information of the epidemic situation with WHO, international organization, and other countries through the IHR Focal Point channel. Recently, Vietnam has basically control of COVID-19 disease. Till date, none of the outbreak has occurred in community in Vietnam. However, in order to maintain this achievement, Vietnam has deployed safety criteria in responding to COVID-19 outbreak. For example, we create safety criteria for hospital, for school, for hotels, and for factory, requested on people to regularly wear masks in public health. For example, in hospital, in supermarket, in transportation station, and also in public conveyance. At the same time, we encourage people on mass media to apply the message of mask wearing, social distance, disinfection, health declaration, and no mask wearing. In the coming time, Vietnam will continue to apply strict measures on management of immigration, supervision of community, and especially in hospital with high-risk people, early detection, and effective treatment of the outbreak in line with establishment of small-scale social distance, so as to ensure effectively handling of the outbreak. We believe that with above-mentioned measures, Vietnam will continue to maintain effective prevention and control of COVID-19 outbreak. On this occasion, I would like to take this opportunity to convey great thanks to all member states in WIPRO, and thanks WHO for your sharing information and experience in prevention and response to COVID-19. And we look forward to continue support and cooperation from all of you. Thank you very much for your attention.
Thank you very much, Dr. Dang, and so pleased we were able to resolve our connection issues earlier and have you join us. That was another incredibly rich set of perspectives and experiences. So for the impossible task of trying to synthesize and respond to those, I'd now like to bring in again Dr. Quang Tran. Over to you.
Thank you very much, Angela. And again, I would like to start with my great appreciation to all the excellent panelists from 6 countries with valuable reflection and experience in the different country contexts. One single most important lesson from all the countries is collective health and safety are based on individual actions, and individual actions are driven by social norms. The government leadership is essential, the role of the health sector is critical, but the community engagement is the key to success. We have seen from the different countries that building and maintaining community support from public health methods, including non-pharmaceutical intervention, is critical for the success. Here are some of the important lessons that we have learned from the countries experience sharing today. The COVID-19 pandemic has provided us with an opportunity to rethink, research, and refocus on the role of social norms in shaping the individual behaviors. For example, why it is that mask wearing is mostly accepted in social norms in Asia, but has been resisted in other parts of the world. Secondly, the human behavior are complex and they are informed by social norms. But social norms can be also changed. This takes time, persistence, and commitment, but it is possible and can have an important impact on public health. Social norms around continued adherence to protective behavior such as hand washing, mask wearing, and physical distancing will be important part of the new normal, and it is illustrated by Japan's experience on enhancing 3C environment and creating inclusive society for the new normal. Social norms also grounded in different country social and cultural contexts, and there is no one-size-fits-all approach to social norms change. And Australia's experience is valuable for us to think about the balance between social norms and enhancing people's behavior in responding to the pandemic. We all have seen from all the presenters that communication and community engagement are very important parts of the public health response to COVID-19. For sharing the most updated information, providing the public health advice, and establishing and strengthening the social norms, and building and maintaining the community support for public health matters. There were some great examples shared by Fiji, Cook Islands, Vietnam, and New Zealand in today's panel. As our regional director already mentioned about the importance of the regional solidarity and cooperation, we could see from the all speakers that the importance of the solidarity and collaboration, and since the earliest phase of the pandemic, countries in the region was sharing information, working closely together from the very beginning of the pandemic. It's not unique to our region, of course, but it is an important part of our approach. And countries in our region come together, as no country is safe until every country is safe. So once again, I would like to thank you very much for Excellency Minister and panelists for your great intervention and valuable reflection. I would also like to thank our Regional Director, Dr. Takeshi Kasai, for your great leadership for the Western Pacific region. And thank you, Professor Jeffrey Schacht, the Chair of Lancet Commission, for this excellent opportunity for Member States and WHO to share our experience of the Western Pacific region. And I would like to thank you, Angela, and hand back to you. Thank you.
Thank you so much, Dr. Huang, and thank you again, as Huang said, to all of our excellent panelists. That was a lot to pack into 2 hours, but I think we've been able to highlight some really important lessons from our region. To close now, I'd like to come back to Professor Sachs first, and then Dr. Kasai to provide some opening remarks. So Jeff, back to you.
Thank you all for wonderful presentations and also for your wonderful work. It's very heartening to hear your approaches, which are very rational, very kind. As we heard in New Zealand, the expression is be kind, and very inclusive. And I think that it is these values, together with the technical excellence, that accounts for the superb performance of an entire region of nearly 2 billion people to suppress this pandemic. It raises a lot of very powerful information for us in the Lancet Commission to share with other countries, which we will do in a statement to be issued at the end of this year and published early next year. It raises puzzles for me because I understand what happened in my country. I don't fully understand what happened in Europe, but both had very, very poor performance. Let me just say that in the United States, just to give you a 2-minute synopsis, we had no preparedness under the Trump government. They had ripped up the game plan, as it were. I don't know how prepared we would have been anyway, but the Trump administration had thrown away whatever was available from the previous government. So there was no AFSED, there was no preparedness strategy, and our Centers for Disease Control was suppressed by the politicians in the White House. We did not exercise border control, as you know, even after the borders were supposedly limited. Tens of thousands of people continued to travel from China without any monitoring. People walked in to the US for months through March with no questions asked in our airports. If you can imagine, not a temperature, not a name, not any information whatsoever. The genomic evidence suggests that the outbreak in New York, my city, came from Europe. Of course, probably via China originally, but in any event, it came from Europe. And there was absolutely no monitoring whatsoever of the borders through March. We had no contact tracing and testing throughout the United States for months because everything was left to local governments that had no experience and that were completely overwhelmed early on and never even understood to catch up until today because there was no message about doing contact tracing and testing. We have no quarantine. We have recommendations of self-isolation, but people go home and then infect their family members in the houses. So we have no quarantine capacity whatsoever, no safe isolation, and a large proportion of cases are in households and, of course, in our congregate settings of nursing homes, retirement homes, prisons, where there were mass outbreaks and no control. We had no crowd behavior. Indeed, the President of the United States led massive rallies throughout the United States, cheering his supporters to not wear face masks in rally after rally that led to local outbreaks. So our political campaign, led by the president, spread the disease. He was the super spreader of our country. Of course, there was no messaging that was coherent. The opposite. Don't wear face masks. Open up your business. Don't close down. It's not serious. It will go away. And we had right-wing protests all over the country repeatedly. People with guns, because in America, you come with guns to protest. This is a crazy country. So this is another part of it. There was no sense of community, no sense of social responsibility. Now, having said all of that, I understand why in the United States we've had 300,000 deaths and why we have 200,000 new cases per day, because everything you described, we do the opposite in the United States. It is completely self-inflicted. What is a mystery, though, is why Western Europe has been just about as bad as the United States. This, I do think, is somewhat puzzling because Western Europe is a lot more rational than the United States. People don't come to rallies with guns. They don't have President Trump as their president. They don't have crazy politicians the same way, but they did have a massive outbreak. It seems to me there was no border control, little cooperation within Europe, no contact, very little contact tracing, which is very weird. Of course, and probably the best governed country, or one of the best governed countries in the world, Sweden, just had the wrong policy response. So that was an absolute professional misjudgment, unfortunately. But other countries just did not do contact tracing. There is no sense of quarantine also. And I think basically our politicians in Europe and the United States are afraid of the public. So they didn't want to put on strong measures. They were afraid of the backlash. So they did not really explain, really tell the truth. Maybe they didn't understand themselves, but they did not anywhere force anything. Whereas the good behavior that you've described is people have to behave. And then they understand why. They have to be in isolation and they're monitored, or they have to get testing. When I suggested that people needed to be tested in New York, I was told that's impossible. We can't force anything. This is voluntary. And so I think there's a kind of freedom of irresponsibility that is cultural and quite deep. you add Trump to that and you get disaster. So this is not a full explanation, but I think a partial explanation. It is a mix of culture, preparedness, and specific politicians. And it adds to a very disastrous brew. But these lessons are extremely important for the incoming government in the United States, because now we will have a decent president, a very nice man, very rational, and a rational team. This will be the first time we've had somebody sane in our leadership, and this will be a very important breakthrough for us. And I will be sharing these lessons with the new public health officials in the United States. Believe me, this is a very, very important set of lessons. So I want to thank you. Please take care, because we're counting on you to continue all success. So when I see outbreaks, I want you to get them under control, please, and keep them under control, because you are our beacon of hope in the world. And I want the Western Pacific region to stay that way. We will share these lessons. I want to thank Dr. Kasai and Dr. Angela Pratt for their leadership to enable us to share these lessons widely. I'm going to continue to count on you for that, because this is extremely important. And let me close by wishing everybody well. Thank you for your leadership. Thank you for the opportunity to be together with you, and a happy new year. And really a year in which next year we really end this pandemic with vaccines and better behavior and better politicians in the United States. So this is my hope. Thank you very much.
Thank you so much, Jeff. And it's really been a pleasure to collaborate with you and your team from the Commission on this event and on some of the lessons that we can learn from this region for others, as you say. I'd now like to come back for the last word to the Regional Director, Dr. Kasai. Adi, over to you.
Yes, thank you very much, Angela. And thank you very much, Professor Jeffrey Sachs, for us to organize this excellent forum together with the Lancet COVID-19 Commission. I would like to also thank all the panelists for sharing such an experience that you had in the past 1 year. We've been working so hard in the past 1 year. So when I listen to your experience, I feel that story has been a long time ago. But I also confirm that many of the lessons you shared have been already incorporated in the regional advice. So thank you very much for that. I'm sorry, DG Nyamfu from Mongolia, because I know that you've really invested in this area and you fully utilize that capacity being in this response to COVID-19. But I know it's not just only that. You continuously analyze the new information and refine, which always impress us. And all this, the regional advice, you're the first country try to analyze and then tailor into your country. So I will really make sure, work with the Professor Jeff to incorporate also your lessons. Now, colleagues, I heard very important message from the Kenneth of the Singapore. He mentioned about the vaccine, but he also mentioned that it cannot be a silver bullet. And it may not end up our break immediately. So 2021, it's going to be the year. We have to continue to work hard. But as we've been doing as an upset practice, we respond, but through that response, we continue to strengthen our capacity. And I heard from Cook and then Fiji that they've been using this as an environment to make a right decision to upgrade their health system. And so hope that not just responding to COVID-19, at the end of next year, we have even stronger capacity to respond to a future outbreak. As we've been keep discussing, our region needs to prepare for influenza pandemic, not just for the COVID-19. So again, let's work hard, and WHO will make sure that we'll be together with all of you and all the member states. And lastly, actually, this forum was proposed by Australia our very close allies, Brandon. And I wanted to really thank his advice for us to organize before we close this year. So thank you very much, Brandon. And thank you very much for Jeff and then Jeffrey, and thank you very much for all the panelists. And be safe and be healthy. Thank you very much, Angela. Back to you.
Thank you, Adi. Thank you again, Jeff, and all of your team at the Lancet Commission. It's been a pleasure to work with you on this, and we look forward to doing so more closely in the future. Again, thanks to all of our terrific speakers for your excellent insights and perspectives. And finally, thanks to everybody who's been watching online today. We know there's been several hundred of you, so thank you for joining us. That's all we have for today. That ends our forum. Bye for now.